Hello, everyone. Good evening. I'm Dr. Helen Burney, and I'm the Director of Sexual and Reproductive Medicine at Indiana University. And it is my pleasure to moderate tonight's SMSNA webinar series on physician burnout and work-life balance with Dr. Omer Rahim. I want to thank the SMSNA for this opportunity and all of you for joining us tonight because we know your time is valuable. I don't think there's a more important topic for us to learn about or that impacts our livelihood more than this. Change slide. And change slide. I'm excited to introduce two phenomenal speakers that we're going to have with us tonight. We will have Dr. Raj Pruthi, Professor and Chair of UCSF Department of Urology. Dr. Pruthi is a urologic oncologist and internationally recognized expert in minimally invasive robotic surgery for the prostate and bladder cancer. His research is focused on surgical innovation, care pathways, and quality of care. And more importantly, in his role as chair, he's been tackling health economic issues to better understand the drivers of faculty productivity, compensation, and burnout. He has explored urologic workforce, gender disparity issues, as well as factors that impact career earnings or predictors of dissatisfaction and burnout, as well as understanding the impact of workflow initiatives that include implementing a scribe. We also have Dr. Kyle Richards, who is an associate professor of urology and the associate program director at the University of Wisconsin and chief of urology at the William Middleton Memorial VA Hospital. He is fellowship trained, a urologist in urologic oncology with a special interest in treating patients with bladder, prostate, kidney, and testicular cancers, both open and robotic approaches. He is a health services researcher who has interests in quality improvement projects aimed at streamlining healthcare delivery and efficiency for all patients, as well as physician burnout. We could not be more excited to have their expertise with us tonight. New slide. Next slide. So burnout is so rampant in our field of medicine. And as physicians, many of us went into medicine because we want to help people and because it's altruistic nature. And it's that nature that's actually predisposing us to burnout. We see one more patient. We add on one more case. We stay late to finish that paper. And then this builds up and it impacts all of us, old and new physicians. It has detrimental effects on one's well-being. And if you go on social media, you see posts everywhere here that talk about burnout. They talk about suicide. They talk about work dissatisfaction, people choosing to actually leave medicine after all the years and effort that we put into training. And with COVID, this has only amplified it and made it worse. So there are many factors that impact burnout. And our speakers tonight are going to get real with you. They're going to talk real life and practical tips. So with that, I'll turn the start of our webinar over to Dr. Rahim.
Thank you, Helen, for this beautiful introduction, and really I'd like to thank also the SMSNA committee, education committee for supporting this important, webinar tonight on burnout and life-work balance. Really, before bringing our great speakers tonight, I'd like to also, tell the audience that we're going to leave the question and question and answer discussion at the very end of the talks. So really, I'd like to, kind of open up this webinar by showing this picture of a famous cruel Greek king who condemned to move this heavy rock from the bottom of the hill to the top of the hill and only watching it roll back again and again. And this is, he did that for eternity. And this is in today's world is burnout. Next slide. The burnout in urology has been obviously rising over the last few years now. The Mayo Clinic published series of publication on this. 2014 was the last one, or one of the recent one before pandemic, and showing about 64% of urologists are burned out. The AUA got interested in this, and through the consensus or the census of the AUA in 2016, the data show that 4 in 10 urologists were burnout. Something really striking among our workforce in urology. Next slide. So, in 2019, the Mayo Clinic survey also showed that urology is not quite as bad as we thought compared with other specialty in medicine, but we are really fell down to the bottom of the list when compared with other specialty when it comes to work-life balance. Again, very, very shocking to many of us, because we choose this field as a field, surgical field, that has this balance between work and life, and we enjoy what we do. Next slide. So there are many reasons, obviously, why burnout, and our great speaker is going to talk in details about this, in their talks. But I want to remind the audience about the top 5. I think we all know this. Use the electronic medical record, the EHR, EMR, by 64%. Reason why urologists are burned out: workload, 54%, falling revenues, and increasing overhead, 52%, prior authorization requirement, 39%, and appreciative patients and unreasonable patient expectation, 35%. So there are more to that. And with that, I'd like to hand the mic to Dr. Pruthi to tell us more about it. And the podium is yours.
All right. Thank you. And I don't know if can everyone see the slides okay?
Yeah, perfectly.
So this is an important and timely topic. And I think when I began to talk about it, I would get a little bit of a pushback and concerns. Is this really an issue? Is it something fabricated by millennials? They just don't get it. Being a doctor is hard, right? We always knew that, or the younger generation doesn't really understand what it is. It's but I think there's certainly significant. This is a significant issue, and one that, at least talking about it, is the beginning of addressing the issue. Practicing surgery is stressful. I mean, the most stressful professions have a high level of responsibility, limited control over the outcomes, and medicine's always been on the short list of those with high stress. Days are filled with intense encounters, emotional needs that come from patients' illness and injury. Can be a draining environment. And we're expected to be perfect. If we're not perfect, or even if we are, we're subject to second guessing and even litigation. 10 years into practice, things can suddenly feel mindless or stale, and this can be especially deflating after many years of school and training. And our practice environment's also changing. We're losing control, and it's unsettling to think about what our careers will look like in the future. Healthcare reform poses many challenges and frustrations. We're faced with burdens of over 50 years of exponentially growing regulations: DRGs, CPT, PQRS, ICD-10 now. I mean, ICD-10 has added a level of complexity, absurd complexity. There's actually a code for being sucked into a jet engine, second encounter, under ICD-10. We're also facing changing scientific and technological environment. 100 years ago, medical knowledge doubled about every 150 years. Today, it doubles about every 75 days. Then there's the bureaucratic burdens of medical practice that was mentioned. Getting paid, which interfere with our core values and goals and genuine patient care. And that's something I'm going to just touch on, a concept of moral injury rather than burnout, which maybe, and we can discuss this as I think maybe a more apt term. Dr. Rahim mentioned the EHR. Unlike many industries in which advances in technology have improved efficiency, this has increased our clerical burden for physicians and can distract from meaningful patient interactions. A recent time motion study has shown that for every 1 hour that a physician spends in face-to-face contact with a patient, they spend another 2 hours on administrative and electronic documentation, and yet another 2 hours after work on so-called pajama time.
Honey, look. He's playing doctor.
Yeah, that's doctor, all right.
With all of these changes and frustrations, burnout can come quickly. It can affect anybody. It does have a disproportional effect on healthcare providers, police officers, teachers, those whose work involves constant demands, intense interactions with people that have great physical and emotional needs. Characterization of burnout remains a relatively new pursuit, really over the last decade. The largest study done by Shanafelt at the Mayo Clinic in 2011. I'll just show you this, and you can just take a look at sort of these these lists of a variety of adjectives of what it burnt out versus being engaged, dependent versus self-directed, and numerous others. The term burnout was first used in 1974 to describe symptoms related to occupational stress. And Christina Maslach, who's a social psychologist from Berkeley, developed the first widely used instrument, the MBI, as it's called. And it operationalizes burnout in three-dimensional syndrome consisting of emotional exhaustion, depersonalization, and reduced personal accomplishment, acknowledging a number of other symptoms, including physical exhaustion and feelings of ineffectiveness. I just want to show you this. This is the MBI for healthcare providers. So it's about 22 questions. I'm not going to go through it in detail, but just wanted to at least show you what the MBI is. And I would encourage people to use it in your groups, in your divisions, in your departments. I remember at the University of North Carolina, when I used it first, I actually got some feedback from other chairs saying, do you really want to ask this question and know what the answers are? And the answer is, I really did want to know that, because, you know, as always, until you measure it, you can't be afraid of figuring that out. In the general population, the incidence of occupational burnout is about 28%. In physicians, it's almost twofold higher at 54%, and what seems to be a rising trend. This is some of the data that was already shown by Dr. Rahim. I won't spend too much. The 2014 paper showed urologists at highest at 64%, which admittedly to me was a number that surprised me. I always thought we were the nice, happy surgeons. And in fact, been asked like, why do I think that? And I don't know the answer to that. My theory was like vascular surgery was actually relatively low. And my thought is they kind of knew what they were getting themselves into, the vascular surgeons. And then we had different expectations. And again, I'll zip through this. You can see this is a busy slide of where we're kind of somewhere in the middle of the pack. And the AUA census in 2016 for the first time really addressed this issue of burnout in our specialty. And, I think this showed in perhaps a more robust number given the larger sample size of a burnout of about 40%, as was mentioned. So we may not be as bad as we thought we were at 64, but still thinking 2 out of every 5 of us are burned out is really nothing to be proud of. Some more interesting findings from the census, highest in multi-specialty groups, almost 50%, lowest in academics. You see this this curve with age, kind of this highest in sort of the middle of the career. We did a study looking at the converse of this, job satisfaction, a few years ago. So this is the opposite, and we saw the same thing, this U-shaped curve, which is fairly typical in many professions in and out of medicine. In fact, this is reminds us of the U-shaped curve of happiness, popular in behavioral economic circles for many years. And this little dip there, I am actually right there at 55. So I think I'm right at that bottom. But a lot of theories on why does it go down and then come up later. I'll talk a little bit about potential causes. It seems to affect those who are most dedicated, conscientious, and motivated, qualities that often lead them to submerge ourselves in work until there's nothing left for us to give. To put it another way, traits that define a good urologist: commitment to patients, attention to detail, awareness of our responsibility may put him or her at a greater risk of burnout. A number of studies have shown that there may be other environmental factors, decreased autonomy, excessive administrative tasks, which may contribute to stress. When we're looking for employment as a urologist, we see amazing opportunities filling our inbox. And this is actually a real ad I received a couple of years ago for a urology opening, promising good life, good pay with time to enjoy it all. I think for surgeons, an honest one would probably read something like this: join our practice, work long hours, difficult hours, deal regularly with life and death situations, make substantial personal sacrifices. These are attributes of surgical practice, along with the long, difficult training that attract individuals of particular character and determination. I mean, this is us, right, that pursue these jobs. And we share an unwritten code that includes coming in early, staying late, meeting multiple deadlines, never complaining, keeping emotions or personal problems from interfering from work. Certainly hallmarks of dedicated professionals that should be celebrated and rewarded. But I think there's a fine line that separates dedication from overwork. If left unchecked, overwork can lead to counterproductive, unhealthy, even self-destructive behaviors that affect ourselves and our families and even patient care. During training, long hours and lack of control over our schedules indoctrinate us with habits that are counterproductive to achieving this balance. And I would like to, we often use the word work-life balance, and I think really probably a better term in my mind is work-life integration. How do we integrate these things? Because I think we don't shut it off at 5 p.m. or 7 p.m. Although I did mention to Helen that my recommendation to her was not to answer emails after 7 p.m. at night. During training, the coping strategy of putting our personal life on hold may create a habit of delaying gratification. Things are just going to get better after residency. And we maintain this habit as we enter practice. Rather than reclaiming our personal lives, we delay it longer, whether to establish our practice, become an associate professor, or getting a grant. And I want to talk a little bit about work hours as causing burnout. Many surgeons work more than 60 hours. The median in urology is 57 hours, in contrast to the US work week, which is 34. So it makes it actually tough to figure out the effect of work hours because we all work such long hours that it limits the ability to see the relationship between hours work and burnout. Although I'll show you a couple of things. This is a study that where we looked at factors that, this was actually the predecessor to the census of 900 urologists and job satisfaction. And a few things that affect it include salary. We're happier when we're paid more. This is actually a common finding in most professions. Academic practice setting and lower work hours approach significance. We do see in the AUA census a relationship between work hours and burnout. And even in this Medscape report, work hours were second only to the bureaucratic burdens and just ahead of EHRs. And then I want to talk, what are the consequences of physician burnout? The impact, I think, goes beyond the physician themselves, includes consequences for patients and even for healthcare systems more broadly. For individual physicians, burnout affects work satisfaction. Although many surgeons believe we're more resilient than our colleagues in other fields, the traits that combine with the workplace environment place us at particular risk for overwork and imbalance. It can harm personal relationships, result in substance abuse, is associated with poor health, hypertension, cardiac events, as well as issues such as depression and suicide. In a study of 2,000 full-time academic physicians and scientists, 1 in 5 reported significant depressive symptoms. And this was higher actually in younger faculty members. In an ACS study of almost 8,000 practicing surgeons, 38% had symptoms of depression, and 1 in 16, 6% had reported thoughts of suicides in the past 12 months. Only 26% sought help. I just want to show you finish up on this important issue of suicide. Suicide is a disproportionate cause of mortality in physicians. Compared to other professions, a male physician's proportionate mortality ratio from suicide is up to 3.8-fold higher than the other professions. And this is even higher in female physicians. I mean, I think the estimate is 400 physicians die of suicide each year. I mean, that's several 737 planes of physicians, several medical school classes going down. And I think, unfortunately, we in medicine have a low priority on our mental health, despite evidence that untreated mood disorders and problems lead to suicide. Too often, depression remains untreated until patient care is affected. For physicians seeking help, there may be negative repercussions: discrimination, licensing, privileges, hindrance to professional advancement. And despite having access to colleagues for treatment of depression, regulatory workplace barriers, I think, dissuade us. I want to finish up with discussion of consequences of burnout. It can affect quality of care, medical errors. The more burnout, the greater the impact on patient care in a dose-response relationship. In an ACS study, burnout and depression were significant independent predictors of medical errors. Interestingly, work hours and call were not, but burnout was. It also affects healthcare organizations. Dissatisfied workers are less productive and more likely to leave or choose early retirement. Physician turnover can cost up towards $1 million each and accounts for up to 6% of an institution's operating budget. In addition to the issue of medical errors and decreasing patient satisfaction and litigation, which is also costly. Just as the consequences are multifactorial, the solutions also need to be multi-pronged. And I'm going to touch on this quickly and leave it to Dr. Richards to talk. I want to talk broadly. I think there is a desperate need for alleviating the burdens of documentation. The processes need to be streamlined and include physician stakeholders. Look to others to perform tasks so we can perform at the top of our license. We talked a little bit about scribes, for example. I think it should be encouraged at the highest levels, NIH, to better understand these impacts of work-life balance on healthcare providers. The CMS has actually begun to address these issues and has announced an Office of Clinician Engagement, I think, which just shows us now at least there's some attention on the national level. Other macro level changes can occur at the level of payers, simplifying billing and coding. The American Board of Medical Specialties can help make the process of maintenance of certification, licensure easier. You can integrate the EHRs here to let them work for us. And I think we need to have our state medical boards where disclosing burnout and mental health conditions should not be public or punitive, but private and supportive. Institutions can play an important role in addressing burnout. I think it's a blind spot, and monitoring physician satisfaction and well-being should be a quality measure, just like we prioritize patient and staff satisfaction. And I don't know if your institutions do that or not. I think if administrators' bonuses were tied to an institutional metric of provider satisfaction, we might see some very different changes. Some have advocated that this be a fourth aim. I'm just going to skip through some of this. We talked a little bit about medical scribes. And we showed that, in fact, implementation of scribes is cost effective and, in fact, increases efficiency, productivity, and net revenues as early as 1 and 3 months of implementation. To finish up on this point, I think institutions can look at lean, other process improvements, participatory management, inclusion of physician leaders who work in the trenches, kind of avoiding punitive carrot and stick approaches in favor of environment fostering autonomy, mastery, purpose, I think can make a big difference. But why don't they do this? I think sometimes it can be felt to be cost prohibitive or maybe just slow to see or not soft. And ultimately, I think Dr. Richards is going to talk about it, it falls upon us, as we're all aware, we're sometimes the worst patient. As the saying goes, the cobbler always wears the worst shoes. I just want to kind of show you this briefly. This is an essay by Dr. Bill Lines, who's a urologist. He actually is a trainee at Stanford years before me and approached me about this. And I'm just going to show you this and give you a moment to read this a little bit of his essay, where I thought it was very courageous of him to write about what his experience was. I mean, it's a very sad essay, but I think it's very poignant. And as I mentioned, it's 400 physicians a year. And I don't hear people talk about suicide in medicine. I just want to spend the last minute here talking about this idea of burnout. And I don't think that burnout really captures the components of what this injurious process is. We focus on existing symptoms of physicians and not underlying causes. Mm-hmm. So I think burnout may overlook real potential solutions. It may not help point to the solutions within our profession and healthcare systems more broadly. Burnout suggests that the fundamental problem lies within the healthcare provider themselves. Accordingly, health systems and programs focus on physician resilience and wellness, including forums to discuss problems, symptoms providers face, elective or urgent support systems. We have something here, Code Lavender, they call it, or taking care of our own, which all strive to ease the provider stress and improve the resilience, hiring wellness officers, creating wellness programs. These are all undoubtedly important steps to alleviate the symptoms of distress and support for the burned out provider, but they don't address the underlying cause. And they focus on symptoms of burnout alone, maybe short-sighted or a Band-Aid for a deeper injury. To this point, Brian Bowman, who is the chief medical officer and founder of the Well MD Center at Stanford, used a statement, which I've loved: you can't yoga your way out of burnout. I think a more accurate description would be the moral injury. So this term was first used to describe the symptoms experienced by war veterans. It's really basically PTSD. So it's when a physician feels, somebody in the military feels like they betrayed what they felt was morally right. They killed somebody, for example, by someone who holds legitimate authority, that they go into battle and they commit something that is against their moral well-being in a high stakes situation. So it's been applied to other areas. And I think it's when we act in combat or whatever it might be that transgresses against our deeply held moral beliefs. I think it more generally refers to an individual's moral conscience resulting from an act perceived as a moral transgression, which produces found emotional shame, psychological, social, cultural, spiritual aspects of trauma. And again, I think that this is where we lie, right? We're all working towards the goal of trying to provide the best care possible for our patients. How do you answer the call to the masters to do what you pledged under the Hippocratic Oath, which is always to do what's in the best interest of the patient? With every patient encounter, you're in a bind. You're not able to do what you're trained to do. You can tolerate that if it's an occasional event, but when it's seemingly betrayal that's happening every day, it's kind of a death by 1,000 cuts. And I think that's probably really what we're seeing. And once we eliminate the moral injury, which points to what the problem is, then I think then we can begin to address the issues of burnout. It's not that we aren't working really hard, it's that we're having to make decisions that go against our core beliefs. And to finish up, I want to kind of leave you with this. So this is kind of a story of a Cherokee giving advice to his grandson. So the grandfather announces that there's a fight going on inside him, a terrible battle between two wolves. One is anger and greed and envy and arrogance, grudges, resentment, misery, full of cowardice and snarling and fearful. The other is happy, joyful, serene, grateful, compassionate, at peace. Each person has these wolves inside you, he says, and inside every other person too. The child's eyes widen. But grandfather, which wolf will win? And the wise Cherokee simply replies, the one that you feed. So I think it's time to feed your practices with compassionate leadership, collegial terms, and a culture that promotes excellence. And I think Dr. Richards is going to talk just about this. I'll stop sharing. Thank you.
Thank you so much, Dr. Protheus. A wonderful talk and really touches a very important aspect of burnout. And thank you for sharing all the stories. Obviously, I'm sure there's a lot of questions, but with that, I'd like to kind of turn over to Dr. Richards to give us more in-depth knowledge about this important topic, and we'll leave the question to the end. So, Dr. Richards, the mic is yours.
Thanks. The slides look okay to everybody?
Perfect.
Great.
Yep.
Just going to change my view real quick.
Haley, can you advance the slide?
Good. No, I'm good. I just was trying to change my view, but I think I'll leave it as is. So thanks to the SMSNA for putting this program together, for the invitation. I'm really honored to be here this evening, to be part of the discussion. I think Dr. Pruthi, great job sort of kicking this off. Just a few disclosures, nothing that relevant to what I'm speaking on tonight, but I am on the NCCN guidelines panel for penile and bladder cancer. And I'm just going to sort of kick off my section by asking a few thought-provoking questions. And I'm going to go through these kind of slowly to give people some time to ponder the questions that I'm asking. And the first one is, how many of you believe that you have a purpose? Right? And it could be at work, it could be at home. You could have multiple purposes, but how many of you actually believe that you have a purpose? That's me right there in the middle. It's surrounded by a bunch of other women helping with the surgery. So I love this picture. And the second question I'll pose is, how many of you know what your purpose is? That's my oldest daughter trying to figure out if her purpose is to be a robotic surgeon someday. So do you know what your purpose is? Now, these are my daughters cheering after I came home after a long day of work, so they were excited to see me. So how many of you know what your priorities are? Could you list them out right now? If I was sitting in front of you, if we were together in person, having a discussion, and I asked you, what are your priorities? Do you know what they are? Do you separate them out if you know what they are? Your priorities, what are your priorities at work? What are your priorities at home? Are they the same? Do you integrate them, as Dr. Pruthi was sort of alluding to? How do you sort of come to grips with that, with your priorities? And do you know what they are? And sort of the last thought-provoking question to sort of kick this off is do you believe that your institution is committed to change? Do you believe that? Is that something that you see at work in practice? Is it happening, or is it just something that we talk about? Is it actually happening? I think it's something important that we all have to sort of grapple with. So this is the only slide that I have that shows some data. My talk is a little bit less on data and more on sort of philosophical questions. And I think, you know, what we've heard a lot of so far, and I think many of us have heard this from our own institutions, is that, you know, they seem to have our backs regarding burnout, but when it comes to what are some of their suggestions, you know, what are some of the suggestions from health systems, it goes something like this. It goes something like, well, you know, you just need to be more resilient, Kyle. That's really what you need to do to deal with all the work. Or they might say, you know, Kyle, what you really need to do is you need to, you know, exercise a little bit more, eat better, maybe get a little bit more sleep, meditate, and that'll help with all of your burnout issues. And while those solutions are certainly helpful, they don't really address many of the root causes of burnout, right? And I think Dr. Pruthi hit on a lot of these, right? It's, what are some of those root causes? Well, it's doing work that maybe we don't find that fulfilling. It's inefficiencies within our workplace, maybe not having enough support staff, not enough nurses and techs to help us to do, you know, the great work that we need to do. How many of us have been asked to see more patients in less time, right? I mean, that's not that helpful. That's not very fulfilling. How many of us have to click, you know, the EHR clickathon that we have, where we have to click, you know, 10, 12 times just to order a CT scan? You know, that certainly doesn't help. And how many of us have felt like they've been commoditized by their institutions, that we could be replaced, and that the institution wouldn't really miss you that much. That's not a good feeling to have. And healthcare institutions, they often have different priorities than what we have as providers. And so how can we combat that? So if burnout is a diagnosis, getting to the data I've presented here in front of us on this slide. So if burnout is a diagnosis, what this study did is it tried to figure out what are some of the treatments for that diagnosis. And what it did is these authors, they surveyed members of the Western section of the AUA, and this is hot off the presses, just came out in urology practice last month. And listed here are the initiatives that were felt to be very effective by the survey respondents. And most of the initiatives on here are things, like exercise, mindfulness. I find it funny that there's a stress management seminar on here that was felt to be very effective in 17% of the respondents. The one that was most effective, and we've talked about already, is hiring a scribe, as well as hiring an APP. However, I'm not really totally convinced that our health systems are ready to hire scribes and APPs, personal scribes for each and every one of us. So I sort of, they're not quite ready, so we can't wait, right? There are people that are leaving the profession or committing suicide, which is horrible. We have to address this, I think, from a different angle. And the angle that I come at is a little bit more philosophical. And this, I am a big fan of Dilbert. Growing up reading the Sunday Funnies, this was one of my favorite cartoons to pick up on a Sunday morning. And as Dilbert is waking up in bed, he says, "Why should I get up today? What is my purpose in life?" He says, "Well, I'm hungry. A toasted bagel would taste great." And as he sits down to have that bagel with his dog, he says, "Maybe the purpose of life is eating bagels." And his dog replies, "Well, you shouldn't try to think on an empty stomach." And I think this cartoon really hits the nail on the head. And so what does purpose mean? What does it mean, to me? What does it mean to you? For me, it's really a belief that you're here for a reason. It's not just a random occurrence that I'm sitting here tonight talking to you all. We're all here for a specific reason. And if you believe that you have a purpose, it can really add a lot of depth and meaning to your life. It can create joy and fulfillment in your daily activities that you're carrying out. It can give you a compass to help guide your journey. And it can also sometimes have a religious or spiritual foundation. I'm for full disclosure, a practicing Catholic, having grown up in the faith. So for me, I come at it from a religious perspective and as a faith-based perspective, but you don't have to come at it from that angle as well. You can have purpose in the absence of organized religion as well. But the first step, I think, is to believe that you have a purpose and that you're here for a specific reason. So now I wanted to share with you a little bit about how I came to my purpose, and a little bit about what my purpose story has looked like. And my purpose currently is, at work at least, is to take care of patients with bladder cancer. This is one of my patients and his wife that insisted that we take a picture prior to his cystectomy a couple of years ago. And he allowed me to post this picture with his permission, of course. And you can see on many of my slides, I have these logos that my wife, who's an artist, created for me. That's a logo, sort of an artistic rendition of a bladder. So I'm quite passionate about bladder cancer, and that's clearly what my purpose in life is taking care of patients with bladder cancer. Many of you on this call are more interested in sexual medicine, and that perhaps that could be, that's your purpose in life. We each have to sort of figure out what our purpose might be. And when I started medical school, as I'm sure many of you also felt as well, was for many altruistic reasons, was because I felt it was a calling to a greater calling to help others and to cure the sick. Yet somewhere along the line, that ideal kind of gets pushed into the background. And you start, at least for me, I clearly that my purpose of why I started along this path to medicine in the first place was somewhat lost. Got sort of replaced with, learning medicine and the new language of medicine and learning how to operate and take care of patients. You kind of can lose sight of what your purpose might be. And I felt like when I finally started practice 7-8 years ago, that finally I made it, that things were going to start looking up. You had finished all your training. Yet I remember as I started practice feeling a little bit of an emptiness, that something was missing, that there's got to be something more out there. And it really came to a head for me one day when I was talking to my PA. And my PA I'd been getting some feedback from some of my patients that my PA was not showing enough, was not the most respectful or compassionate towards some of the patients. So I said, I'll use this as an opportunity to sort of coach this individual and see if we can work on this. And after discussing it with my PA, my PA came back to me and said, you know what, Kyle, I don't see what the problem is. I come to work, I do my job, and I get the work done. And that just didn't sit well with me. It was almost like a light bulb went off. And I remember thinking, there is so much more to what we do than just get the work done, right? We are here for much more than that, right? That patient sitting across from me, they're not just a number. I'm not here just to sort of click through the EHR and click boxes and get the work done, right? We're here for a much higher purpose. So at that point, I kind of got back to basics and said, look, I'm here to cure cancer. I'm here because I have a passion and a drive, and my purpose is taking care of bladder cancer. And I sort of have kept that as my personal mantra. And I started to build my practice around this so that I could spend at least 50% of my time or more of my time working in my purpose area. There was a study out of Mayo Clinic that suggested that if you spent about 20% of your time doing things at work that you enjoyed, that you would be happy and fulfilled. And I think that number is a bit on the low side. So I think if you're doing work that you find enjoyable more often than not, so 51% of the time or more, then I think you'll be more likely to be happy and fulfilled at work, and hopefully less likely to succumb to some of the symptoms of burnout and the moral injuries that can come from that. Now, it's not always possible, right? We oftentimes are asked to do things at work that are outside of our primary purpose area. And so for me, it's bladder cancer. I also, you might have secondary or tertiary purpose areas. So secondary purpose area for me is research, tertiary is education. And, but, there are certainly times where I, have to do things that I think are outside of my purpose areas, or see patients that, don't have bladder cancer, but they clearly still need to be taken care of. And I want to tell a story about Scott Egner that kind of addresses this. He shared this with me. He's one of my mentors. We crossed paths when I was a fellow at University of Chicago. And I've told the story before. He's shared this story as well. So I apologize if you've already heard it. But when he started his practice at the University of Chicago, he was very interested in building a testicular cancer practice. And to do so, he had to sort of convince his division and department that he was the man for the job. And starting off as a young faculty member can be kind of hard to build your practice. So he agreed to take on a lot of the testicular pain or calgia patients, knowing that some of those patients probably had testicular cancer. Well, a majority would not, but that would give him sort of more leverage and an ability to sort of build his testicular cancer practice. I thought that was a little extreme, agreeing to take on a lot of patients with testicular pain. But the way that he was able to make it more meaningful is he designed a clinical trial where he could study different treatments for testicular pain, which many of the treatments have been poorly studied, but he could at least design a clinical trial to try to address to help these patients with testicular pain. And he made those encounters more meaningful and more purposeful. He was able to repurpose the encounter so that it was something that fit in his purpose area, which he's also very passionate about research. So that's something that, you know, you can consider in your own practice. If there are things that are cropping up that you're like, man, I really just don't want to do this. This is not interesting. This is just not something, you know, I'm fellowship trained or I'm a subspecialist. See if you can reframe it or repurpose it so that it can still fit and still make it be interesting, whether it be academically. Is there a quality improvement project? It doesn't have to be this grand scale, you know, randomized clinical trial like what Dr. Egner designed, but there are ways that you can try to reframe things or repurpose them so that they can still be meaningful for you. The other thing I will say along these lines is don't be afraid to say no or to set boundaries. And that can be really hard to do when you're first starting out in practice. But it's important that you get that, you know, get practice in saying no and setting boundaries, especially if you're being asked to do a lot of things that are maybe outside of your area of interest or expertise or outside of your purpose area. And it's good to practice doing this because it can be really hard saying no and setting boundaries when you're first starting out. So to sort of close on this concept of purpose, so what are my recommendations for those of you that are seeking purpose? First off, think of your work as something more than just work, but working for a higher purpose can be really rewarding. And I think everyone should really ponder this concept and try it out. For me, bladder cancer made the most sense, but for many of you, it may be challenging to figure out exactly what your purpose area is. So identify what makes you happy, what fills you with joy at work. Identify what you're passionate about, and those are likely areas that are your purpose areas. And then spend time in some deep thought, contemplation, prayer, meditation, whatever it might be, so that you can really figure out where you want your life to go and where you want it to, what you want it to look like. So I'm going to shift gears a little bit from purpose into more about priorities. And I think this Dilbert cartoon sort of hits the nail on the head as well. And one of the workers says, as he shows up at work in the morning with his coffee, so I thought about work all last night at home. So what do I do now that I'm at work, right? I mean, how many of us have, you know, how many of us bring work home, right? I mean, it happens often, and it could be physically, you know, you're checking emails at home, or you bring your laptop home and you're writing notes, or it could be mentally, right? How many of us are just mentally, we're thinking about work at home, or that's what I struggle with the most is I'm ruminating about patients or operations that I'm going to perform the next day or the next week. And I'm not mentally present when I need to be present for my family. So what are your priorities? This is my wife, my beautiful wife, Jessica. So what are your priorities? Can you readily list them off? If I were to ask you right now, could you, 1, 2, 3, 4, just list them off what your priorities are? What I do is I think priorities are really important. I sit down with my wife and discuss priorities on a regular basis. I try to not separate out work and home because as we talked about earlier, I think we don't live our lives in these sort of separate silos. It is integrated. And I try to make sure that my priorities are in alignment with my wife's. I think that for me is really helpful and really important. And I tell, my wife knows what my priorities are, and I give her carte blanche to call me out if I'm making decisions or choices that are out of alignment with my priorities. So she a lot of times spouses might be hesitant to do so or intimidated. She's not in medicine, but she understands, what I do very well. But I've created an environment where she's not intimidated. She's a very strong woman, and I've empowered her to let me know if my choices are out of alignment with my priorities. And that's been very helpful for me. And it can be hard, right, to stay consistent with your vision or your purpose and your priorities. And I think you have to build good habits to do this. And for me, this is a picture of the chapel at my when you walk into the hospital I work at. There's this cute little chapel, and what I do is every morning I get to work. I walk in this chapel and I sit there in the dark for 10 minutes. I set an alarm on my phone, and I just sit there and I think about what my purpose is, what my priorities are. And I also think about what I'm thankful for. I practice sort of going through what I'm grateful for and thankful. I think having a gratefulness about you just sort of lifts your spirit up. And it's a great way to start the day. So I spend 10 minutes in the chapel. Sometimes I'll do it in my office with the lights off. It just gets me going. It gets me in the right mood, the right frame of mind that I can tackle just about anything. And you don't have to, you can do it anywhere. It doesn't have to be in a chapel or a place of, a church or anything like that. You don't have to pray or meditate, but it just helps you to it's helped me tremendously. And it's 10 minutes a day. It's a commitment, but it's time well spent. So I would encourage everyone to try this out. I don't think you'll regret it. And these are my girls and these are my daughters. And I show this because I think it just gives me hope for the future. And I just say, I try to live with the heart of a child. I mean, it's the joy of reeling in that big catch, the serenity of doing lakeside yoga. When I come home from work, my kids, they don't ask me how many surgeries I did or how many patients I saw in clinic, right? That's not something they're asking. They don't care. They just want, my wife doesn't, she says, hey, are you going to take out the trash? That's what we talk about. So this is just a reminder that you have to balance things out and keep everything. This keeps me grounded and keeps me in perspective. So I just want to close by listing, these are my priorities and these are my life priorities. Like I said, I don't break it down by work and home life. I sort of lump it all together. So number one is my wife. Number two are my kids. Number three is work. 4 would be my extended family and friends. 5 are my hobbies. And then 6 is exercise. And, some people will have a different list, right? Your list might look different than mine, and that's totally fine. You can't really say anybody's priorities are wrong. It's your own list. And I think knowing your priorities can really give you a compass and a balance to your life, can provide you with some direction, and it can allow your purpose to grow. So just to summarize and give you some concluding thoughts. So the first step, number one, is to believe that you have a purpose, both at work and outside of work. You have to have that belief, right? And I don't know if I've convinced you, but I hope I have, that you and I are here for a purpose. Number two, you got to figure out what your purpose is. You may have multiple purposes, and your purposes may change based on where you are in life, are at in life, right? So keep reassessing what your purposes are at various points in your life, but figure out what your purpose is, and that will lead you to happiness. Number three, create priorities that will allow your purpose to flourish. So if you create your priorities kind of around what your purposes are and where you value certain things, then you'll be swimming and not sinking. And I think if you accomplish all these things that I talked about here in the past 20 minutes or so, that you'll be able to find fulfillment, and you'll be less likely to succumb to burnout and the moral injuries that are a result. So thank you so much for your time. And it's been a real pleasure having this discussion.
Thank you, Dr. Richard. That was wonderful. Thank you so much. And I don't know we have time for questions, but I think we have 5 minutes to spare. So Helen.
I just thank you both so much for this. I think for all the listeners here too, I think both of you bring up some really important things that regardless of what our environment is, right? Regardless of whether we're at an institution that we feel is being supportive of this, or we have the setup like a scribe, or we have the work environment to be able to mediate burnout, there's so much more that we can do internally. I think I'm going to take your words to heart, and I'm literally going to do this tonight, and I'm going to write down, I think it's great for all of us, write down your priorities, figure out, what your purpose is, or at least solidify it more, and realize that all of these things are internal things that we can do. Even when our environment around us seems really rough or seems really draining and we seem exhausted at work, that these are things that internally can help recharge us. It can help fulfill us so that you come with a more refreshed mindset of, hey, I'm empowered. I can control this. I can start making these suggestions and solutions. I know for me, when I'm in a better headspace, solutions seem to pop up quicker in your mind of, oh, maybe I could convert that afternoon to virtual visits, and that would make me more relaxed, or that would allow me to get home sooner, or whatever it is, so that you can really meet those priorities. So I just cannot thank you both enough for really this wonderful lecture tonight that I think can really be game changing for all of us that were here to listen to it.
Absolutely. I echo that as well. Helen, I want to question Dr. Pruthi. You have a question for us or comment?
Well, I was just going to make a comment, and
Yeah,
I
of
love
course.
seeing Kyle's family there. And as somebody who's now kids are adult children and out of the house, don't forget the prioritization of the family. And, there's look, I've been in academic institutions, for a long period of time. There's a paper called about Simone's Maxims. I don't know if you've ever seen it. Simone was like a leader in academic medicine. And what is his maxim number one? And it sounds very cynical, but it's institutions don't love you back. I know it sounds very cynical, but your family does. That is your legacy. Just don't ever, I don't want people to forget that, because early in our career, we can think, we can forget about them. They're the first group of people to get squeezed out, right? Is our family, and we don't want them ever to become an afterthought. And I think, so I love seeing your family, Kyle, on that, because I think that demonstrated clearly where your priorities are.
Absolutely, Dr. Pruthi, and really just follow on that. Obviously, institution doesn't love you back, but the way I think about this really is there's a personal and also professional, risk factors, if you will, or barriers. So, you touched on personal, like purpose of life and family, but can you tell us what other risk factors we should look for in terms of red flags in a person? How can I know that this is I'm burned out? From both of you kind of perspective. Because to me, it's almost a silent kind of disease inside us. Yeah. And we, but how can we recognize, and we should say it and acknowledge it?
I think it can be silent. It's gradual too. It's not like, I don't think a switch goes off one day and you're burnt out. It's a gradual thing. And it's insult after insult that starts to add up. And, I recognize it in myself when I start getting, really short with I find it when I get short with patients, or I cut them off, or I say, I find myself being more abrasive maybe with patients that I'm interacting with, or even staff. Sometimes in the OR, I'm a little bit, more short with some of the help. So, that's the first sign for me. And then I'm like, oh, I gotta do something. I gotta get right, better headspace, as Helen put it. I like that term. I think that's great. So that's what I see in myself.
Agree. I think when you start to see people kind of maybe act or behave a little bit not, unusually, or not who they are, and you kind of see that. And again, I think it's being short with people around you.
Right. Absolutely. We talked so much on neurologists, but I hope at the residents. Just a quick note on that. Do you feel our residents also need education about burnout? I do feel that, but from your perspective, how do you manage? How do you strategize? How do you manage stress and burnout in residents?
Can I make just a quick comment about that? If you look at satisfaction in life, when people enter medical school, they're actually above average of the population. By the end of medical school, they're below average. So it's early in the life cycle of the learner that this all starts happening. And I think residency is starting on that trend. I think institutions, we've started here a curriculum on wellness for our trainees. And I think, again, I mentioned like this idea of like, it'll all be better after residency and not claiming your life, during residency. And I think it's support, like, you ought to go to the dentist, a couple times a year. And that can be during your day, or, I used to have no problem walking out the front. I mean, I would walk through our clinic, like when my kids were a little bit younger, to tell people that I was going to my son's lacrosse game. And it was very deliberate, right? It's not sneaking out the back stairwell, because I wanted the people to see that is acceptable and it should be done, and the residents as well. And I will actually make comments to them about, like are they exercising, and when they're eating 3 slices of pizza after the cystectomy, maybe make a comment that, I know we feel like we deserve that after that cystectomy, but we feel sorry for ourselves. So I don't know, Kyle, what are your thoughts on that?
It's so important. I mean, our residents, that's the future of urology right there. So, I think it starts with them. And as a program director, associate program director here in Wisconsin, it's a top priority, to something we talk about. And it's something that we try to address and be more proactive about. So the culture has to change, and I think, we made a step in the right direction with the 80-hour work week, but that was the initiation probably of improving on resident wellness, but we can go further for sure. And we need there's a lot of work that we need to do to ensure that our residents are well taken care of.
And I just add to that. So I guess modeling our behavior too, right? Starts from the top down, and we have to model the right behavior. I've eaten plenty of slices of pizza after cystectomies, but
It's good for us.
Just 1 and not 3.
Deserve that. Yeah. Great. Helen, last word for you.
I think you guys summarized it really well. And I think, all of us as attendings, we get so busy in our own too, that we do need to remember to check on our residents who are helping us so much and learning along the way too, and have a little less control over maybe some circumstances. So this has been excellent. For all of you listening, we do have some more SMSNA webinars that are next month. Omer, do you want to?
Yeah, absolutely. It's coming up on March 22nd at 7 p.m. Central Time by Dr. Perlman and Cartman on sexual AIDS and social medicine society. So stay tuned. This is going to be exciting to know all about the sexual AIDS. Thank you, everybody.
Thanks,
Thank you for everybody tuning in. Take care. See you guys.
Bye.